Hello, I would like to talk about endotoxin adsorption in the treatment of septic shock. My name is Jakub Smiechowicz, and Professor Barbara Adamik is the co-author of the lecture. We work in the Department of Anesthesiology and Intensive Therapy in Wroclaw Medical University in Poland. I am a clinician, and Professor Adamik is responsible for research. Here are disclosures. When the pandemic is over, it's worth visiting our beautiful city. And Wrocław University Hospital is a modern hospital, one of the largest in Poland. But we have also an old part of Wrocław Medical University that is still in use. And Richard Pfeiffer, famous microbiologist and father of the term endotoxin, was working in the building shown on the photograph. Endotoxin is a lipopolysaccharide. It is the major component of cell wall of gram-negative bacteria. It is one of the most potent immunostimulatory compounds known in nature. It triggers overactivation of the innate immune system, and it is presumed to be a key component in sepsis. Its function is to act as a protective permeability barrier. The release of endotoxins is associated with disintegration of pathogenic bacteria, but also with the natural production of outer membrane vesicles. Humans are extremely sensitive to endotoxin, and even very small doses cause severe symptoms. Intravenous injection of endotoxin in healthy volunteers results in severe cardiovascular response, causing fever, tachycardia, hypotension, and cardiac depression. Endotoxin plays a very prominent role in the pathogenesis of sepsis. It is one of the most important alarm molecules that trigger a release of cytokines that may lead to multi-organ failure. Endotoxin is recognized by the toll-like receptor 4. It activates signaling cascade and triggers widespread activation of the immune system. The adequate response to infection causes killing of bacteria and results in patient's recovery. High burden of endotoxin triggers excessive, uncontrolled response that leads to multi-organ damage and death. Septic patients that have high endotoxemia have much higher mortality. We analyzed the endotoxin activity level in 157 patients with septic shock. The group with endotoxin activity above 0.4 had a much higher mortality than the group of patients with low endotoxin activity, regardless of the infecting microorganism. So where does the endotoxin come from? Well, not only from an abscess or other source of infection. In the heart, there is a huge number of bacteria cells in our body, and as a consequence of translocation, small amounts of endotoxin can be present in the blood. But in patients with gut barrier failure, there is an increased translocation of bacteria and toxins. It occurs in splenic ischemia or in shock states due to endothelial dysfunction. Adamik and co-workers studied endotoxemia in patients during open heart surgery. They used intestinal fatty acid binding protein as a marker of intestinal injury. And endotoxin was significantly elevated after cardiopulmonary bypass, notably when the bypass time was higher than 90 minutes. And it remained elevated even after 24 hours after surgery in the group of patients with prolonged bypass time. Endotoxemia causes a lot of harm to organs. This figure shows complexity of pathogenic mechanisms of the acute kidney injury in the context of sepsis or major surgery. Acute kidney injury affects 30 to 60% of ICU patients. Septic shock is a dominant cause of AKI in the ICU, and hemodynamic alterations are only partially responsible for that. It is rather a result of a complex interaction between vascular, tubular, and inflammatory factors, and toll-like receptor 4 pathway triggered by endotoxin plays a key inflammatory role in AKI. Although the exact mechanism underlying renal dysfunction in sepsis remains unknown, there's a lot of evidence pointing to prominent role of toll-like receptor 4, which is expressed in the kidney. Its activation causes cytokine and chemokine release, leukocyte infiltration, and that results in endothelial dysfunction, tubular dysfunction, and altered renal metabolism and circulation. Toll-like receptor 4 receptors are located in tubular epithelium, in the glomeruli, and vascular endothelium. Endotoxin is filtered in renal glomeruli, internalized by S1 proximal tubules to toll-like receptor 4, and interactions between endotoxin and S1 tubules results in severe oxidative stress and damage in neighboring S2 segments. Direct renal damage by endotoxin can explain the occurrence of AKI and sepsis, even when hemodynamic parameters are well controlled. And here on these microscopic pictures, we can see endotoxin that concentrates in S1 tubules adjacent to glomeruli. 2 hours after endotoxin administration, oxidative stress is observed in S2 segments, but not in S1. Recent studies led to discovery of 2 additional TLR4 independent lipopolysaccharide recognition systems. First is membrane-bound transient receptor potential channels. Activation of these channels on the neuronal cells generates pain during inflammation. An activation of the TRPV4 channel in the airway epithelium leads to the production of nitric oxide that facilitates the pathogen clearance from the airways. The second TLR4 independent lipopolysaccharide recognition system is intracellular and is based on caspase-dependent sensing of lipopolysaccharide in the cytosol. The uptake of lipopolysaccharide monomers, or in the form of outer membrane vesicles, into the cytosol is facilitated by high mobility group box1 and RAGE, and in the cytoplasm, endotoxins are sensed by caspase, leading to induction of pyroptosis and activation of coagulation. Pyroptosis is a beneficial defense mechanism against bacterial infections by minimizing tissue damage. But when overactivated, pyroptosis causes sepsis and septic shock. So many different ways to recognize lipopolysaccharide underscores the importance of lipopolysaccharide as a pathogen-associated molecular pattern. And there are multiple forms of cell death, including apoptosis, necrosis, and pyroptosis. Pyroptosis is a programmed cell death mediated by inflammatory caspases, which is characterized by the formation of large pores on the plasma membrane. Oh, let me see it, it's here. Excessive activation of pyroptosis can lead to widespread cell death, extensive inflammation, tissue damage, and organ failure that results in lethal septic shock. Endotoxins contribute also to acute lung injury by induction of pyroptotic cell death via activation of inflammatory caspases in lung endothelium. The microscopic picture shows interstitial edema, inflammation, and lung injury after exposure to systemic endotoxin. The pathomechanism is shown on the right. The lipopolysaccharide enters the endothelial cytoplasma, triggers caspase-dependent pyroptosis, resulting in the release of cytokines, fluid leakage, leukocyte infiltration that leads to acute lung injury. Liver is an important participant of the body's reaction to endotoxemia. Endotoxin uses both TLR4 and caspase pathways to induce high mobility group box1 release from hepatocytes. And the complexes of high mobility group box1 and lipopolysaccharide here are taken up by macrophages and endothelial cells via RAGE and induce pyroptosis and death. This process may play a central role in the pathogenesis of sepsis. We performed a study to evaluate the effectiveness of endotoxin removal from the bloodstream of patients in septic shock and endotoxemia. In patients with septic shock, and endotoxin activity higher or equal to 0.6, we performed a 2-hour hemoperfusion treatment with Alteco LPS adsorber. We compared the LPS group to the standard treatment group, where endotoxin activity was below 0.6. The majority of patients had intra-abdominal infection as a source of sepsis, and as expected, gram-negative pathogens were cultured more often. But of note, 1/3 of the septic patients had a documented gram-positive bacteria, fungi, or mycoplasma. Some of these cases had high activity of endotoxins, even though gram-negative bacteria were not detected. In fact, only 1/3 of patients with gram-negative sepsis had a high endotoxin activity level, and in 2/3 of them, the endotoxin activity level was below 0.6. We can see here that endotoxin elimination was effective, and the endotoxin activity decreased significantly after the treatment with adsorber. Effective endotoxin elimination resulted in a significant improvement in hemodynamic parameters and of organ function. Arterial pressure was significantly higher, and non-adrenaline dose was significantly lower after treatment with the adsorber. It resulted also with lower lactate level and improvement of organ function as measured by SOFA score. Similar results to ours were obtained in an Italian study. In a retrospective analysis of 52 patients with septic shock unresponsive to conventional therapy on a high-dose vasopressor therapy and with at least 2 organ failures, endotoxin removal was performed as a rescue therapy. The results were improved hemodynamics, improved organ function, and reduced mortality. The randomized controlled trials with endotoxin adsorbers performed in Europe and North America had conflicting results. The Italian study, EUPHAS, polymyxin B hemoperfusion, significantly improved hemodynamics and improved organ dysfunction and reduced 28-day mortality. On the contrary, the French study, the Adamik trial, no benefit was observed in polymyxin B hemoperfusion group. So there was a lot of expectations with EUPHRATES trial, and also a lot of discussion in medical journals. And EUPHRATES trial was different because it had a very meticulous protocol with sham treatment group, endotoxin activity measurement, and the largest number of recruited patients so far. The trial was performed in the intensive care units in the USA and Canada, and patients with endotoxin activity of at least 0.6 were included in the treatment group. But the results of the study was negative. Main outcome, mortality at 28 days, was not reduced in the polymyxin B hemoperfusion group. So it was a question why. So it was found that in patients with endotoxin activity very high, exceeding 0.9, the burden of endotoxin was very high, and it simply exceeded the capacity of adsorber. The adsorptive capacity of polymyxin B filter is in the range of 10 to 20 micrograms of endotoxin. And the total amount of endotoxin that possibly also distributes in the extracellular space could be actually much higher than 20 micrograms. And this could be the reason why the PMX hemoperfusion treatment in these patients did not provide benefit. In the subgroup analysis that was performed, where septic shock patients without extreme endotoxemia were analyzed, in the group of patients with endotoxin activity in the range 0.6 from 0.6 to 0.9, the mortality at 28 days was significantly lower. Arterial pressure was higher, and there were more ventilator-free days. In conclusions, the findings of the study were considered as hypothesis generating, and a future study was announced to validate this result. And also, this future study is called Tigris study, which is a follow-up of the EUPHRATES study with selected population of septic shock patients with MODS score above 9 and the level of endotoxemia between 0.6 and 0.9. So you will be waiting for the results. But maybe also the timing of endotoxin removal is important. In the study published this year, Japanese researchers investigated whether the outcome in septic shock patients is affected by the time of endotoxin removal initiation and the location of the infection site. The results of the study were very impressive, as it demonstrated that delayed initiation of endotoxin elimination treatment is associated with much higher mortality. In particular, the group of patients with intra-abdominal infection benefit most from early, that means within 9 hours after catecholamides start, endotoxin elimination treatment. How about COVID-19? So there is a preprint paper available at medRxiv in which endotoxemia and circulating bacteriome severe COVID-19 patients were investigated. So we know that enterocytes in ileum and colon express the angiotensin-converting enzyme 2 receptor, and SARS-CoV-2 virus has been detected in stool. The researchers studied 13 ICU patients, and in 42% of them, the endotoxin activity was actually high. Most of blood samples from COVID-19 patients had presence of bacterial DNA. So it has been speculated that bacterial translocation from GI tract might complicate severe COVID-19, and bacterial products might be another possible contributor to the cytokine storm. Do experts recommend endotoxin removal? There is no clear answer. But although we don't have any expert recommendation regarding the use of blood purification techniques, there is a vast amount of evidence to support endotoxin removal. So there are 2 adsorbers on the market that target specifically endotoxin removal. The older one, toramyxin, is in routine clinical use in Japan since 1994. This is a hemoperfusion adsorptive filter where polystyrene fibers are coated with the antibiotic polymyxin B. The other one is Alteco RPS adsorber. It is also a hemoperfusion adsorptive filter, but instead of polymyxin B, that is known for its efficacy, but also for toxicity, a synthetic polypeptide bound to porous polyethylene discs is used. Cationic peptide captures negatively charged endotoxin molecules. The treatment time should be between 2 and 6 hours, and the blood flow around 150 milliliters per hour. So, to conclude, endotoxin is presumed to be a key component in sepsis. High burden of endotoxin triggers excessive uncontrolled response that leads to multi-organ damage. Septic patients with endotoxemia have higher mortality. Endotoxin has a prominent role in the pathogenesis of septic AKI, which greatly increases the risk of death. Translocation of bacteria and toxins that occur in sepsis due to gut injury amplify inflammatory response and contribute to multi-organ dysfunction syndrome and death. Delayed treatment of sepsis results in increased mortality, and available hemoperfusion adsorptive filters effectively remove endotoxin from the bloodstream of septic patients and have a potential to improve the outcome. And thank you very much for your attention. Goodbye.